My girl, by your resistance so bad. And my girl, by your resistance so bad. It's so bad, it's so bad, 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 it's so bad. It's so bad, it's so bad. Na, na, na,
Good afternoon, everyone. This is the KCU AMR-Club once more for another session of interview. And today we have a friend, Mr. Munyaneza Moses, who will talk about antimicrobial resistance with us. We'll discuss this with him. So will you please introduce yourself first for everyone?
Oh, thank you, Madam Nwera. I'm called Moses Munyaneza. I am a clinical officer and currently pursuing Bachelor of Medicine and Surgery at King Caesar University.
Thank you so much. Well, Mr. Munyaneza, the World Antimicrobial Resistance Awareness Week starts between the 18th and the 24th. And on occasion of this, we want to discuss the antimicrobial resistance, this global threat. And so from the point of view of your experience as a clinician,
Yes.
we would like to know if you first of all know what antimicrobial resistance is.
Okay, thank you. Yeah, I know about antimicrobial resistance as a tendency of microorganisms, the fungi, the bacteria, the viruses, tending to not respond to antimicrobial agents over time. When they are exposed to the antimicrobial agents, they tend not to respond.
Yeah.
That's what I know about.
Okay, and before we get back to that, I would like to know if you have encountered during your years any cases of resistance in the treatment of a microbe.
Okay, thanks. I have been in practice, clinical practice now for 7 years, and I've met a number of cases of antimicrobial resistance. But a particular case in point that I would like to put forward is multi-drug resistant tuberculosis.
Tuberculosis, that's
Yes.
a killer.
Tuberculosis. We have treated, I've participated in the treatment of multi-drug resistant TB. The facility in which I work is in Kisoro district, which is in Kigezi region, and our regional referral hospital is Kabale Regional Referral Hospital. So according to the treatment structuring in Uganda, multi-drug resistant TB is treated at regional level. So we had a patient whose identity I will not reveal, and we diagnosed him at our facility with tuberculosis via the ZN. So when we diagnosed him with TB, we picked a sample and sent it for gene expert at our district hospital. But we started treatment with anti-TB drugs, the usual anti-TB drugs.
The conventional.
Yes. And the gene expert results kind of delayed to come, and the patient was on the first line anti-TBs, but the patient was not improving, kept deteriorating. And when the results came, gene expert showed that this patient had MDR, and the patient.
Would you please tell us what's MDR?
MDR is multi-drug resistant tuberculosis. So it is usually arrived at when a person shows resistance to rifampicin, as is depicted on a gene expert report. So we got in touch with the district authorities, and this patient was repatriated to Kabale Regional Referral Hospital, where he started his treatment. So that's the case.
Okay. And the course of the treatment, how was it? At the referral, of course.
Okay. Of course, on receiving the results, we immediately stopped the other first line because we realized it couldn't help this patient, and he was admitted at Kabale Regional Referral Hospital for 2 weeks.
For 2 weeks?
Yes. And this person was started on a course of treatment for 18 months.
An 18 months treatment, guys?
Yes, 18 months. The first 2 weeks were the initial, where he was started on strictly under admission. Then after, he was attached back to our facility because treatment for MDR is strictly DOT and facility-based DOT, where you have to go and swallow under supervision of a health worker. I would say the cost was immense because now, one, this person was being fed by the government, and of course government gets money from taxpayers, so that was a cost in all the population. Two, this patient used to make monthly visits, reviews at Kabale Regional Referral Hospital. From Kisoro to Kabale is 80 kilometers. So the journey, this man the patient was being given transport to go there, to and fro. And it had the cost implication also on work, because remember, he has to come to the facility every day, making travels to the facility to take drugs, goes home every day for 18 months. So that's a huge cost, I believe, which, if it wasn't for antimicrobial resistance, obviously it would have been cheaper. 6 months, the patient would be cured at a less pill burden and less cost to the government and to the patient and the whole family at large.
Okay. So you mean each time we encounter a patient with multi-drug resistant tuberculosis, it's the government that encompasses the treatment of the patient?
Yes, it is government, one, in the provision of drugs,
yes,
and supporting the patient, of course, by also their partners, development partners. Like in our region, we have USAID, JCRC. Those are partners in health, which help in meeting the cost. But obviously, it also has a bearing on the taxpayers, because the procurement of drugs is using taxpayers' money. So you find the cost is being distributed to the government, to the person himself, and to the family, which becomes too much of a burden.
Thank you so much, Mr. Moses. It's clear that antimicrobial resistance is not just about, because we repeat all the time that it kills. Yes, that's not the only repercussion. We see that economically it's terrible, not just for the person but for the government too. And imagine if the growth of this phenomenon continues and we face more and more patients with maybe multi-drug resistant TB, which we know TB kills. TB is a disease that kills in pain, for that matter. So if we cannot treat a patient with TB that is resistant to many drugs, and many of them come up, you can imagine the burden on the country's economy. AMR is not just an individual thing. It's not something that the club is doing for laughing sake. It's serious, and everyone should take it extremely seriously. We should spread awareness. People should stop using drugs, misusing drugs, I mean. People should stop sharing drugs, and also in the way you discard these drugs. So Mr. Munyaneza, it was very nice discussing with you. We are grateful for the experience you have shared with us today, and we hope to share more interviews and more moments of discussion like this.
Thank you very much.
Thank you too.